So, good morning, afternoon, or evening, depending where you are in the world. I'm one of your event moderators. I'm Harry Shufflebarger, formerly of Nicholas Children's Hospital in Miami, now the Bailey Institute. My co-moderator is Amit Jain, a spine surgeon from Johns Hopkins University in Baltimore. Next. We have a pretty exciting program today, and this dealing with the long-term outlook in adolescent idiopathic scoliosis. We have three guest surgeon speakers, Dr. Javier Pizones, the partner of Dr. Perez Guso in Madrid, Dr. Meric Enercan from Istanbul, Turkey, and Dr. Masayuki Ohashi from Niigata, Japan. They have exciting topics and will be very informative. Next. And we have two guest patient speakers. Moll, who I've known for quite a few years, is a medical student at Washington University, and Lindsay Ellingson, who has gone from patient to model to mother to entrepreneur, and is a member of the board of directors of Setting Scoliosis Straight. Next. The instructions are pretty simple. Any of you listeners who have questions, submit those through the Zoom question and answer section. Myself and Dr. Jain will pick these up and present them to the presenter who will answer them. Next. This is the agenda. Scoliosis 101 will be a brief introduction to scoliosis on a layman's level by Dr. Jain. Then we'll hear about the long-term follow-up for AIS from Dr. Pizones, quality of life in AIS, and trunk flexibility 10 years after surgery. Then our two patient stories will follow, and Michelle Marks will present the new long-term follow-up study on AIS, and we'll close briefly. Next. The Setting Scoliosis Straight Foundation is a not-for-profit 501c3 foundation established in 2018, succeeding the Harm Study Group Foundation. And the mission is to advance techniques in the treatment of scoliosis around the world. And our vision is a future where children with scoliosis have the ability to live healthy, happy, and productive lives. Next. So I'd like to introduce Dr. Amit Jain. He is a product of medical school at Johns Hopkins and residency there, followed by a 2-year neurosurgery, orthopedic surgery fellowship at the Spine Center at Emory University in Atlanta, Georgia. He returned to practice at Johns Hopkins, and I give you Dr. Amit Jain.
Thank you, Dr. Shufflebarger. Okay, so we are so thrilled that you could join us for this webinar. My name is Amit Jain, and I'll be going over Scoliosis 101, and I'm honored to present this on behalf of the Harm Study Group and the Setting Scoliosis Straight Foundation. So fun fact, the word orthopedics comes from scoliosis. So the word orthos means straighten, and pedis is children. So it came from Nicolas Andri's 1741 book, Orthopedy, which focused on treatment of scoliosis or treatment of straightening children. And as you can imagine, the art of doing this has evolved over the centuries to more modern era techniques. So what is scoliosis? Scoliosis is a lateral curvature of the spine on a PA radiograph. It's defined as greater than 10-degree curve, and it's most commonly curve of the right thoracic spine, but can certainly affect the thoracic or the lumbar spine, and in some situations, the cervical spine as well. So it's really a curvature of the spine on a radiograph. In reality, however, it's a three-dimensional deformity. It not only affects the coronal plane, which we perceive as a lateral curvature, but it also affects the sagittal plane, which can oftentimes result in flattening of the thoracic spine, so a perceived thoracic lordosis, as well as in the axial plane, there is a vertebral rotation that takes place, which can really be perceived as a rib hump, as well as some other scapular anomalies. There are different types of scoliosis. There is pediatric versus adult. On the pediatric side, we often categorize them based on the reason why it exists. So idiopathic being the reason we don't really know. Within that, we categorize it by age: infantile, juvenile, adolescent, or AIS, which is the most common. Congenital, which is a failure of formation or segmentation. Neuromuscular, and syndromic. On the adult side, scoliosis can be either idiopathic, so in other words, continuation of AIS in an adult patient, or it could be de novo or degenerative, which develops later in life because of disc degeneration. Now, it's important to understand that family history is positive in 30% of adolescents. Not everybody's going to have a positive family history, but it's important to ask, and especially in a sibling. Genetically, it's an autosomal dominant condition with incomplete penetrance. Luckily, there is, while there's a common prevalence in the general population, severe curves tend to be more rare. So 3 out of 1,000 patients have curves over 30 degrees, and there's a 10-to-1 female to male ratio for curves over 30 degrees. So hence, we tend to see our female patients more commonly with more advanced curves. Now, back pain can present with scoliosis. It usually presents in 1 in 4 patients at time of initial evaluation. It's important to also check for additional sources of back pain, such as fractures in the pars, Sherman's disorder, disc herniations, and so on. But extensive workup is frequently not indicated if it's run-of-the-mill scoliosis. AIS signs, it's important to note that there can be a variety of features that can be presenting. Oftentimes, families note that their child has their head off center, shoulders are uneven, there's a shift in the rib cage, there's waistline asymmetry, or there's pelvic imbalance. And these are things that the patient or the family member or care provider can notice and important to kind of pay attention to. A lot of time, detection happens at the school screening or at the pediatrician annual visit with a forward bend test. Scoliometer may be used for this purpose, and oftentimes a 7-degree on scoliometer refers to 20 degrees of Cobb angle. It's important to check for other causes of scoliosis. It's important to assess flexibility, really do a thorough neurological exam, as well as if there's pain, important to quantify it and localize it. Now, we're going to hear a lot of amazing speakers today who are going to talk about the natural history of AIS and kind of the long-term impact. Just one thing I would mention is that the curve progression is related directly to skeletal maturity and size. So if you have a skeletally immature curve, it's more likely to progress. And for severe cases, it can certainly affect lung function. Dr. Weinstein had a classic study that showed that curves that are presenting at a younger age with a more severe curve are much more likely to progress than older age with smaller curves. We look at a variety of radiographic maturity markers, and the harm study group has done a lot of tremendous research looking at what markers are appropriate and predict progression, and a lot of exciting work coming out of that. So finally, about treatment, how do we treat AIS? Well, skeletally immature patients, we oftentimes focus on physical therapy or bracing. Bracing is really the mainstay. Surgery can be recommended if the curve is severe. For skeletally mature patients, oftentimes the options are observation or a discussion regarding surgery. So here is an example of a 13-year-old child who was skeletally immature with a high risk of curve progression, who ended up requiring a surgical treatment in order to treat her scoliosis. And now she's back to sports and back to doing what she loves. So thank you very much. And I'll turn the floor to our rest of amazing speakers today. Thank you.
Well, thank you very much. I'll be the next one, I think. Let me show you my slides over here. So thank you for having me here. I'm really excited and happy to be part of this today. And my name is Javier Pizones, and I work in Madrid, Spain. I've been a spine surgeon for the last 18 years, very involved in deformity and scoliosis. And I'll tell you a little bit what we have been doing in the last 2 years. And this is mainly work that my mentor, Paco Sanchez, has done. He's already retired, but he wanted to know what happened to the patients he operated on 30 years ago. So 30 years ago, in the 80s, there was this phenomenous change in surgery. The CD instrumentation, which is the one that you see here, came out, and it replaced the one that we had before. That was the Harrington instrumentation. It was only one rod, and then you had to be 3 months after your surgery laying on bed and with a cast, and then you needed 18 months of subsequent bracing. Now, this CD instrumentation that came in the 80s changed completely the paradigm, because it's As we do today, you operated the patient could freely move afterwards without needing of bed rest and casting. So here, what we wanted to see is those patients that we followed in the 80s and treated by conservative means and then got operated by the age of 14, 15, more or less. What has happened to them in these past years, now that they're 50 years old? What happened in these 30 last years? So for that, we wanted to collect the experience and current attitude of those patients operated back in the 80s with this instrumentation. As you see here in the pictures, the guy with the mustache is my mentor. He operated on all these patients in the 80s and wanted to follow 30 years after that. For that, we did a prospective qualitative cross-sectional study using one thing that is used in psychology. And this is completely different to what we usually do. We usually use something called prompts, which are questionnaires, multiple choice that you can fill in. This was another idea. The idea was to have an interview, 60-minute long, and let the people talk and see what happens. So he was the guy. So my mentor was the one calling the patients and offering them a semi-structured personal interview. It was undertaken by him. More or less, it was 60 minutes, and there was a topic guide that was done by our research team based on 7 different topics. The registry identified 284 patients, but we could finally contact 103, and 100 were interviewed. And there was a very common quote. People felt like they were getting a call from the past. So they really remember 30 years back what happened, and they remember the surgeon and the experience they had. The mean age of the patients now were 47 years old, the mean follow-up 30 years. So the interview covered two different times. First, in the adolescents, what happened, the recollections they have on their conservative treatment and the experience of surgery itself. And then in adulthood, what has happened in these last 30 years regarding adjustment to social environment, back health, physical activity, and current health conditions. And actually, at the end, we wanted to see the overall satisfaction with treatment. But during the conversations, a lot of different topics, subtopics arose. And what we did here is to collect more or less what was common between patients to guide the conversation and have the final results. So the recollection they had from the initial conservative treatment, that being cast or braces, or we did way back before we did electrostimulation or night traction, it was really hard. So they really complained regarding the intensity of those treatments, and there was a group of patients that were really affected by these treatments. And we have to remember that at that time we did traction, and some of them said that they had nightmares till they were 25 years old, or that some of them with night traction cheated releasing the traction during night while their mothers were not watching. For the decision of surgery itself, many patients were driven by the parents' opinion. You're 14 or 15, so you don't make the decision yourself. Your parents usually do the decision for yourself. And the doctors really encouraged this new strategy and instrumentation that we had, and they could experience that. And the experience of surgery was positive. The same thing as the conservative treatment, had very bad memories, almost in all patients. The experience of surgery was positive. The worst experience were the posterior approaches, double approaches. So when we have to go from the back and from anterior, the resuscitation room, or the complications, if there were any. And at that time, we didn't have neuro monitoring during surgery. So those are the cables that measure how your cord is functioning during surgery. And we had to wake up in the middle of the surgery patients to see if they could move the feet. And some vividly remember that wake-up test, and we were surprised about that. Regarding social environment, work and jobs is pretty much the same as in the normal population. So those guys that wanted to study could study a career, and those that wanted to go ahead and work from the first day, they could. Some of them complain of back pain, but it's very similar to the general population, and only 8 had benefits. But we were stuck on one patient, and we really realized with this that we're changing patients' lives. And this was a guy who said that the operation came just when he got an engineer scholarship in university, and he had to give up that scholarship and ended up as a truck driver. So we can really impact on patients' lives. 2/3 of them were married, 2/3 had offspring, and it's really common that you don't receive the epidural anesthesia during birth. Some of them voluntarily didn't want, but some that doctors failed to attempt that anesthesia or secondary to doctor's decision. But we only have 4 C-sections. And we have quotes like, I don't have not wanted to have children because the possibility of transmitting the scoliosis is one thing that stuck us. And I think I haven't had children because the amount of radiation that we receive, and we know that radiation is a big concern among our population. It is true that right now the radiation exposure is much less than it was in the 80s, but still we have to struggle with that. Regarding physical activity, 50% were very active, and you can see that almost 43 of them, so from the 100, could do sports like soccer, skiing, boxing, horseback riding, Pilates, and there are very, very few that felt limitations. So we have from one range that I feel physically very restricted to another range that I could, go with a group of bikers sometimes in routes, very long routes. So there's people doing a lot of things, a lot of sports. Main issue was back health. So back pain, we encountered in 72% of the patients, and some of them were actively treated. But we have to remember that in a normal population, in this age, which is around 50, 65% already disclosed lumbar pain. So it's a little bit slightly higher than in a normal population. This is the important thing. Self-image was not good. So you are mostly dissatisfied with the deformity and the scar. And some of them complain, and you could see here from a residual hump up in the left, or prominent implants down on the left, or maybe with time, with degeneration of the discs that we have below the instrumentation, you can fall anteriorly or to one side. And most of the patients that we interviewed complain of back stiffness. And that is really true, because nowadays surgery is a fusion. So they have perceived back stiffness, rotating the trunk, especially towards the convexity. On concurrent health conditions, we found 3 patients had breast cancer, which is very similar to the rate we found in the normal population, slightly higher. 9 were depressed, 4 had pulmonary pathology. And again, we felt the concerns about the accumulation of X-rays and if that has something to do with cancer. And overall satisfaction with the treatment was good. So most patients were satisfied with the treatment received, although we felt that some of them still have a stigma, because you have scoliosis and you're going to live your life having scoliosis. You're not like a pure normal. You can do normal things and normal activity and work, but you always feel that you're a little bit different than the rest. So quotes like, I have to give up my ballet and I cry for a year, or sometimes I dream that I don't have scoliosis, which really is impactful. And all of them were satisfied. They were satisfied with the work we were doing in the interviews, because they got to reach the original surgeon that treated them 30 years before, and because actually they felt that they were talking to someone that could really understand what they were have experienced through life. So at the end, factors such as dissatisfaction with self-image, low back pain, and spine stiffness were relevant to these patients. But despite this, the great majority were satisfied with the treatment they have received and has allowed them to lead an integrated life in society. So thank you. Thank you for listening to me. If you have any questions, Dr. Shufflebarger, do you know that if any from the audience have any questions already?
There are no questions from the audience. I have a question. This is a tremendous study that you guys undertook. How many ancillary people did you have working with you? Or did Paco do it all himself?
Paco did all the interviews himself. So we were 3 working in this, research coordinator and myself, that I could lead a little bit and organize. But the interviews were undertaken by Paco himself, who operated these patients 30 years ago. It was really happy by doing this. It's very difficult. And actually, some of them came together with their mother, actually parents, but mostly mother, because they wanted to see face-to-face the surgeon that operated on their kids 30 years ago. It was an experience for both of them, I think, patients and surgeon. Really positive. Yeah.
Paco's been a good friend of mine, and I admire him for undertaking this study.
Yeah. So we could see here that actually what we've learned about this, it's that they lead a normal life. Well, Lindsay is here, he can tell us, and Eve can tell us afterwards. They can lead a normal life. They don't feel like their peers, so they know that they have this thing and they have a stigma, a small mental scar, if I could dare say. But actually, they can work, they can study, they can live normal life, they can get married, they can have children. Here we have Lindsay, and they do have back pain, very similarly to the population, but they do have back pain at this time. And they know, I think they acknowledge that they have to be active in sports and they have to take care of their health if they want to be more productive and without pain for the rest of their lives.
And another question for you: do either you or Paco think we're doing any better now than we did 30 years ago?
Yeah, hopefully we are. I think new instrumentation has improved, and I think radiation exposure, for example, is less because the machines we're using right now have less power of radiation, and people are more concerned that they have to live a healthy life and diet and all that. So I think we're doing better, but we need another 30 years to demonstrate that we're doing better than what we did 30 years ago. But I'm positive on that. Yeah.
I see a lot of my old CD patients back, and most of them do pretty well, but not all of them.
Yeah, you have to remember that on those times, 85-90% of the instrumentation was T4 to L4, which we don't do anymore. Now we do selective fusion, so we leave the lumbar spine free to move, and this is a step ahead. I think it will improve the results with time.
You can speak for yourself on that.
Yeah.
Okay, so we're going to move on. And the next speaker is Dr. Meriç Enercan from Istanbul, and he's associated with a lot of the progressive Istanbul scoliosis surgeons and is associated with the Florence Nightingale Hospital. And he's going to talk about comparison of disc and facet joint degeneration and quality of life in AIS patients. Meric.
Dr. Shufflebarger, thank you for the introduction. And it's been a great pleasure for us to share our experience with all of you. So today I'm going to share our experience about the long-term degeneration problem. We all know that primary goal of the AIS surgery is to achieve a balanced spine. But sometimes to obtain a harmony between this obtaining a balanced spine and retaining motion segment can be very challenging in terms of patient management. And hopefully we have many good reports telling that spinal fusion surgery is really effective and really makes positive changes for the idiopathic scoliotic patients. And really we have very satisfactory good results, mainly long-term results. But there is no answer how long is the long term. When we operate an adolescent patient who is 14 years old, an adolescent, 20 years later is the long term. She will be most probably 34 years old, but still a very young individual, and many years for the coming. And especially if we are talking about the degeneration, it's actually not very long term. So when we think about long terms, some questions arise in our patient minds. Will my spine mobility will be reduced? How about the sports? Will I be able to do the same activity level? How it would be? Will I have a pain in the following years? Or will I be satisfied enough? And sometimes these questions really affects patient psychological well-being. So it's really hard to give an exact answer about long-term effect of spinal fusion. But today we will be looking from a broader narrower aspect. Mainly, I will be talking about the disc, lumbar disc, and also the facet joint. Most of us are very familiar with the discs and the function of the disc, but also we have some small joints, what we call facet joints. And the disc approximately do the majority of the works and carry the loads of the almost 80% work done by the disc, and the remaining 20% is supported by the what we call small joints, facet joints, and these two functional units may be a pain producer in the following years, because we have a problem what we call adjacent segment degeneration. What this means, when we fuse a segment, this long fusion segment acts as a single unit after the fusion occurs. So this increases the lever arm acting on the preserved disc. By this way, we will have a loss of motion, and in the remaining unfused spine, there will be a greater mobility, and the strains will be mainly acting on these unfused part. So actually, we are doing something good. We are correcting our spine. We are balancing it, but also we bring some problems, especially increased strains on the unfused part. So this may cause an accelerated degeneration at the unfused part, and especially in the long term, this may become as a symptomatic problem. And especially when we think about an adolescent patient, it's really questionable. So we usually, as a reflex, we try to do shorter fusion. By this way, we try to allow more distal mobile segments, but sometimes achieving balance is very good. If you do short fusion, there might be a residual curve. It might be problematic in the coming years. When we fuse too long, we will limit the motion, and also, as I mentioned, it may bring the acceleration of the degeneration. So this year, we presented our study mainly focusing on the long-term degeneration, mainly at the disc and the facet joints. And we compare our patients. We divided them into two groups where the lowest instrumented vertebrae is L3 in one and L4 in the other group. So as surgeons, saving L4, which means not fusing L4, is beneficial for preserving motion and preventing further degeneration theoretically. And there are very good studies available in the current literature. They assess the functional results, they assess the degeneration of the unfused segments, but most of them done this by using only direct X-rays. I think when we talk about the disc and the facets, we need some more additional information, and MRI can give more detailed value data about this. So in our study, we included the patients with minimum 15 years follow-up, and we evaluate the disc degeneration and facet joint degeneration, and also we compared these with healthy individuals, which means no unknown spine problem or no complaint about the spine. So we included the major curves, which means structural lumbar curves. The lumbar component of the curves are structural, which means not very flexible, and they are big in magnitude. So by this way, we try to evaluate which one is better or which one degenerates slower than the other one. So we have two radiologists which help us during this evaluation. The disc in the upper part, you see the disc degeneration, and we graded over 5 degrees, and grade 1 and 2 and 3 are accepted as almost healthy, but 4 and 5 is problematic. When we come to the facets, grade 1 and 2 are known as healthy ones, grade 3 suspected, grade 4 is prone to cause us complaints. So as I mentioned, these kids are mean age at 14, and when we evaluate them, the average age is 30, around 30s. They're on their fourth decades, and their heights and all the weights are similar. So we compare 17 patients with 12 patients, and we had a small control group. So during the time, good news, our correction was stable, which is good. But what we see is, especially just below the fusion level, the disc degeneration rate is higher than the lower ones, because as I mentioned in the introduction, the disc, the loads accelerate in the next level. But hopefully, when we compare it with the controls, with the healthy individuals, the difference is not so big. So the disc really works 15 years following the surgery. And this is a chart which means unfused spine is similar to the controls. But when we come to the small joints, facet joints, the helping ones, it's very interesting that after below the fusion, you had really significant facet joint degeneration. If you stop at L3, the facet joint between L3 and L4 really degenerate more than the lower levels. But it's critical, if you stop at L4, even you have two levels of facets, they really both degenerate together. I will show you a couple of examples. And according to our experience, disc degeneration, not a big problem after 15 years, but facets may be prone to produce some complaints in the following. But interestingly, don't worry about the long terms. This is what we call SRS scores, which show us the functions of our patients. Really, all groups, I mean the fused ones to L3, L4, and also the healthy individuals really show similar health quality scores, which is good for us. Very quickly, some examples. In this example, 70 years follow-up, we stop at L3. Here you see the discs are okay, and the facets are okay. If you stop at L3, here you see the grades. Another example, which we stop at L4. When we stop at L4, disc is doing well, but you see the facets really degenerate more than the disc. This is almost 20 years follow-up. This is a healthy individual example. I can say stopping at L4 demonstrated more disc degeneration, but significantly facet joint degeneration. But despite these degenerative findings, they are all happy after 15 years of follow-up. But we don't stop at this level. So we also wonder about the functional results, which means the flexibility, and also how about the core muscle strength. Again, we designed a similar design. We compare L3, L4, and healthy controls. And what we did, we measured the lumbar core muscle strength with this 3D rotational device. When you bend in one direction, we measure this device measures the muscle strength of the other part. So when we look at this, really fusion lowers a bit of the muscle strength when they are compared with the healthy individuals, but there are not major differences between L3 and L4 groups. And flexibility, in terms of flexibility, when we fuse down to L3, it shows better forward bending capacity than L4s, but again, not significant. But when we compare the L3 and L4 group with the controls, we see some kind of difference. Again, these patients did not express any pain, and they really give good scores. These scores are all out of 5. So this is an important part, I think. We all measure the satisfaction. We are asking our patients, if you have the same problem, will you have the same treatment? And really, believe me, most of our patients, almost 90% of our patients, really satisfied with the group, and they accept to go the same similar treatment. So L3, as a conclusion, I can say L3 and L4 groups show similar muscle strengths, similar ROM grades, which is decreased when compared to the healthy individuals, but really satisfaction and clinical outcomes are not diminished with these degeneration functions. So I want to thank you all, and this is our own motto: life is motion and motion is life. So we did it for motion. Please stay motioned. Thank you.
Outstanding. That was a excellent overview, Dr. Enercan. I saw a couple of questions in the chat. What do you think? One question and one repetitive theme is: do you think technology has improved over time, where we are now achieving better outcomes for our patients? And we'd love to hear your thoughts on that.
Yeah, it's a very good question. You know, the technology advancements in the technology, the philosophy is really changing. We are understanding the importance of the balance, not only the corneal, I mean also what we call the sagittal balance, which means when we look from the side. So by doing better 3D corrections, I think we will see this degeneration problem less and less. And also the technology, implants technology develops. When we combine this with all these data, we will expect better scores, I think, better outcomes.
Yeah, another aspect of care for these patients is a lot of radiation exposure in terms of surveillance, in terms of monitoring, in terms of treatment and post-surveillance of the treatment. Could you comment on that and how you feel that has changed over time and what families can do to protect their kids?
Well, really, radiation exposure is I think the major concern. Dr. Javier mentions about there might be some increased incidence in the malignancies. So, but also we have new imaging modalities which allows lower radiation exposure. So, what we called there are brand new direct imaging technologies. Hopefully, in our studies we use MRI study too much because there's no radiation exposure or any concern about the radiation. So, and our institution really help us to do this kinds of research, and so it won't add any cost to our patients. So we are lucky we can evaluate our patients without any radiation exposure.
Oh, that's excellent. And then the very last point I just want to touch on is, we focus a lot on flexibility of the lumbar spine. How do you think that changes with advent of motion preserving technologies and techniques, and how your thoughts on the preservation of the lumbar spine has changed?
Yeah, actually, we have the results of long fusions, approximately 20, even 30 years of experience. We have that. Motion preservation is what we give special importance, and there are new non-fusion techniques. But it's really crucial to get the balance. Sometimes we had to preserve the motion, but if the patient is not indicated, that might be prone to revisions and then converting non-fusion to the fusion techniques. So although we discuss with our patients, and my advice to our attendees is discuss all the options with your physician very carefully. Sometimes we jumped into, because the non-fusion is really a magical world. When I even heard it, yes, this is the right thing. It might not be in every case. So we should consider all options. We try to do non-fusion, but don't accept fusion as the bad boy. It's always the golden boy, but really non-fusion techniques have really high potentials.
Yeah, that's very well put. Okay, next it's my honor to present Dr. Masayuki Ohashi from Japan, who's going to talk about trunk flexibility 10 years after fusion. So, Dr. Ohashi, stage is yours.
Sorry. Thank you, introduction. Thank you for the opportunity to present our study. And I will present our previous study regarding trunk flexibility 10 years after spinal fusion surgery for adolescent idiopathic scoliosis. So, I have nothing to disclose for this presentation. Spinal fusion is a primary treatment for adolescent idiopathic scoliosis, AIS, with a curve greater than 45 to 50 degrees. The evolution of surgical techniques past 20 years has provided better outcomes, including greater curve correction and improvement of health-related quality of life, HRQOL. However, the loss of normal mobility in the fusion area is inevitable. Therefore, surgical correction for major thoracic AIS focuses not only on stabilization on significant curves, but also on sparing motion segments below the fusion constructs over time. The concept of selective thoracic fusion is to correct main thoracic curves and minor lumbar curves with sparing motion segments in lumbar spine and maximize retention of spinal mobility. However, the residual lumbar deformity, distal adding on, and postoperative coronal imbalance remain significant problems after selective thoracic fusion. Therefore, the mobility-sparing benefits must exceed the shortcomings of selective thoracic fusion over the lifespan. However, long-term benefits of sparing lumbar motion segments remain unclear. So, our study aimed to answer the following research questions. Question 1. Could sparing lumbar motion segments retain spinal mobility at 10 years after spinal fusion? Question 2. Did flexible spine resulted in better HRQOL at 10 years after spinal fusion? And methods. This is a retrospective study using a multi-center prospective registry of harm study group. Patients with major thoracic AIS and availability of both preoperative and 10-year postoperative spinal mobility data were included. For HRQOL evaluation, SRS-22 scores were also collected. Spinal motion was evaluated with a measuring tape. We measured the excursion between the starting and ending positions in forward and lateral flexion. For measuring thoracic and lumbar forward flexion, a tape was placed proximally on the spinous process of C7 and distally to S1. For measuring thoracic and lumbar lateral flexion, one end of a measuring tape was placed on the tip of the middle finger and the other on the floor on the point directly beneath the middle finger. Then, the reduction rate of spinal mobility from the preoperative to 10-year postoperative time points was calculated according to the formula shown in this slide. In this study, 40% or greater reduction of spinal mobility was defined as substantial reduction. To analyze if sparing lumbar motion segments retain spinal mobility, correlations between the lowest instrumented vertebra, LIV, and the spinal mobility were evaluated. In addition, we compared reduction rate of spinal mobility between the thoracic fusion group and thoracic and lumbar fusion group using t-test. In this study, a thoracic fusion was defined as a fusion with the LIV at L1 or above. To analyze if flexible spine resulted in better HRQOL, patients were divided into two groups according to reduction rate of spinal mobility at 10 years after surgery. For each spinal motion, patients with 40% or greater reduction were classified into the substantial reduction group, whereas the other patients were classified into the non-substantial reduction group. Then, we compared SRS-22 scores between the substantial and non-substantial reduction groups. Results. 151 patients with the average age at 10-year follow-up of 25 years were included. More than 90% of patients had structural thoracic curve with non-structural lumbar curve or Lenke type 1 or 2 curves. With regard to the surgical procedures, posterior spinal fusion was performed in 72% of patients, anterior spinal fusion in 21%, and anterior and posterior combined fusion in 6.6%. Of these patients, 72% were thoracic fusions and 28% were thoracic and lumbar fusions. Preoperative spinal mobility did not differ between the T and T plus L groups. Looking at correlations between LIV and reduction rate of spinal mobility, we found significant positive correlations in all measures of spinal mobility. In other words, the more caudal the LIV, the greater reduction rate in spinal mobility. In both forward and lateral flexion, mean reduction rates of spinal mobility were significantly lower in the T group than in the T plus L group. In consequence, the incidences of substantial reduction of spinal mobility were around 15% in the T group, which was threefold less than those in the T plus L group. Therefore, the answer to the question 1 is yes, sparing lumbar motion segments could retain spinal mobility in both forward and lateral flexion. Next, to analyze the effects of reduction rate of spinal mobility on HRQOL, we compared SRS-22 scores between the substantial reduction and non-substantial reduction groups. For forward flexion, there were no significant differences in all domain scores of SRS-22 between the two groups. On the contrary, for lateral flexion, patients in the substantial reduction group had lower scores in pain, function, satisfaction, and total than those in the non-substantial reduction group. Therefore, the answer to the question 2 is yes, patients with flexible spine in lateral flexion had better SRS-22 scores in pain, function, satisfaction, and total than those with rigid spine. In summary, the more caudal the LIV, the greater the reduction rate of spinal mobility. The incidences of substantial reduction of spinal mobility were threefold less in the T group compared to the T plus L group. Patients with substantial reduction in lateral flexion had lower SRS-22 scores than those without substantial reduction at 10-year follow-up. In conclusion, the benefits of sparing lumbar motion segments are evident and clinically significant 10-year postoperatively. Thank you for your attention.
Well, thank you, Dr. Ohashi, for an excellent talk. Next, we have Eve Moll, who is a medical student at WashU and a spinal fusion patient. She had her spinal fusion 11 years ago, and she's currently applying to neurology. So we are really excited and thrilled to hear Eve.
Hello, everyone. My name is Eve. I am a fourth-year medical student at WashU in St. Louis, and I'm a scoliosis patient. And I'm here today to offer a patient perspective about long-term follow-up from spinal fusion surgery. First, I just want to give a big thank you to Setting Scoliosis Straight for making patient education efforts like this possible, and to all the physicians who dedicate their lives to improving spinal deformity outcomes for patients like me. And special thank you to Dr. Shufflebarger on the call, who is my surgeon. So allow me to give a brief timeline of my story. I was diagnosed with scoliosis in 2009 at age 11. I was an unsuspecting dancer and athlete when I got the rude awakening that my spine looked like this. I wore a brace every night for about 1.5 years, but to my frustration, this curve eventually progressed to beyond 50 degrees. My parents and I sought the care of Dr. Shufflebarger, who recommended a selective spinal fusion of my thoracic spine. Interestingly, a couple other surgeons I had seen for this problem were recommending a total fusion, but we went with Dr. Shufflebarger's recommendation, and he performed my surgery in 2012 at Miami Children's Hospital, now Nicklaus Children's Hospital, when I was 14. This was a very difficult decision, and I was honestly uncertain of what my recovery was going to look like, but I wish I could tell my former self that she was going to do great. Thanks to my family and friends' support, I made a fabulous recovery and I returned to dance in full force the following year. But prior to my return to dance, I was investing heavily in my other passions that were less physically demanding, like painting and art. But I did make it back to my dance studio. Then in 2015, Dr. Shufflebarger and Michelle Marks invited me to share my story at the annual gala for Setting Scoliosis Straight that was taking place in Las Vegas, Nevada. I painted a picture that was inspired by my experience with scoliosis, seen here, to donate for auction at this event as part of an ongoing service project called Art by Eve that I have. I basically create and donate artwork for worthy causes. So I flew out to Vegas with this piece of art and gave a personal testimony for this incredible audience of surgeon researchers. And this whole experience was so cathartic that I really had this sense that I had conquered my scoliosis at this point. Then in 2016, I started college at Vanderbilt University with a sense of empowerment over my diagnosis and a keen interest in medicine, shaped by my experience as a patient. Supportive of my pre-medical dreams, Dr. Shufflebarger actually allowed me to shadow him in his clinic in Miami, where I saw a lot of patients just like you and me at various stages in our scoliosis journeys. These are some films from one of my follow-up appointments that I had as a college student. And these films to me are powerful reminders of how far I've come since my surgery, of the innovative techniques that physicians are using to treat this deformity, and of how grateful I am to be protected from the progressive nature of this deformity while still being able to move and to dance. In 2020, I graduated from Vandy and I started medical school at Washington University in St. Louis, which is where I'm speaking to you all from right now. Initially, I had an interest in orthopedic surgery, no doubt inspired by this experience, but ultimately, I fell in love with the field of neurology, and I actually just applied for residency, which is absolutely surreal. At this stage in my life, I'm thinking a lot about my future career, and my future health. So I followed up again with Dr. Shufflebarger just this past summer, just to make sure everything is still looking okay 11 years after surgery, and it is. These are my most recent films. And so I really celebrate the fact that I am pain-free, active, and flexible 11 years post-op, and I look forward to enjoying good health and, close follow-up with my spine doctors as I hit my 20th and 30th and 40th and, knock on wood, 90th anniversary of my spinal fusion surgery. I also look forward to being a practicing physician someday soon myself. I'm lucky I have exemplary doctors in my life that I can look up to. So, thank you. I take questions now, if any.
Well, Eve, that was a remarkable story and really a testament to you as well as to Dr. Shufflebarger for that wonderful, beautiful journey, as well as for you having the courage to share that a group of surgeons and then group of patients, and really kudos to you in many ways. Sure. Next, I'd like to introduce Ms. Lindsay Ellingson, who is another very inspiring person. She's a spinal fusion patient herself, a successful model, as well as had a career as an entrepreneur. So we're really excited to hear her share her thoughts and her journey.
Hi, everybody, and thank you so much for having me. Yes, as you mentioned, I've been a model for over 20 years. I'm also co-founder and creative director of Wander Beauty, and I have two little boys, Carter and Rowan. And my scoliosis story really started in 4th grade. I was a dancer and a gymnast, as you can see here. When I was in 5th grade, my coach was pushing down on me in the middle splits, and he noticed that the left side of my back was more raised than the right. And so that's when I heard the word scoliosis for the first time. He recommended that I go see a doctor and get it checked out. And then you can see on the next slide, my x-ray. So my x-ray revealed that I had a pretty significant S-shaped curve, two curves. One at the top, when we first had the x-ray, it was 25 degrees, and the bottom curve was 35 degrees. So I was braced immediately for 23.5 hours a day. And this was back in the 90s. So I know that bracing is different nowadays, but that's what my brace looked like. So my life completely changed in an instant. I went from being a gymnast and a dancer to having to wear this back brace, had to give up gymnastics, but I still did dance as much as I could. And then you can go to the next slide. So we, in 7th grade, I decided to wear the back brace only 16 hours a day. I made the dance team, and I just felt like for my own mental and emotional health, during that difficult and delicate time in my life, I wanted to feel like a normal kid. And so I took the back brace off at school and during practice. And then before this, every 6 months, I had received bad news. Every 6 months, I would get the x-rays done, and my curves had progressed. So I just figured, why not try to just have a little bit of a normal childhood? So I took the back brace off at school and at practice, and it was so nice, honestly, because that was a really traumatic time in my life. And then in 7th grade, I had another x-ray that revealed that my curves were over 50 degrees. The top was 54, the bottom was 57. And so surgery was recommended. And as you can see here, I was scheduled for surgery that summer at the Children's Hospital in Los Angeles. My doctor was Dr. Tolo, and he was amazing, super positive. And I remember when I went into his office, he had a book full of patient stories and post-op pictures of his patients doing all sorts of activities, which gave me hope because I didn't know what life would be like with a spinal fusion or if I would be able to dance again. So my surgery went really well. I remember waking up with not much pain. I was just determined to start walking again, to get out of the hospital, get back on the dance floor. So you could see on the next slide, I believe, that picture on the left, 6 months later, I was back to dancing. Seems like a common theme amongst many of us is dancing. So I was back dancing, pretty normal activity. As you can see, I was fused on the right. You can see I was fused to L4, which I'm learning a lot about that today. A little concerned about that. But again, this was in the 90s. So I think the technology and techniques have changed a lot over time. So I really did not feel any physical limitations except for can't do a back bend, but that's okay. I didn't go back to gymnastics, but I was able to dance, and most people had no idea that I had a spinal fusion. I danced competitively in high school and also in college, and that was so much fun. And I kept up with all the other girls. And again, like really hardly anybody noticed that I had my fusion is almost my entire spine. So then after college, my life took another very unexpected turn. I was scouted and I moved to Paris and I started my modeling career. I walked in hundreds of fashion shows for Dior and Chanel and Valentino and all sorts of designers. And, my biggest, takeaway from that is, again, nobody realized that I was fused. Makeup artists, they would see my scar. They didn't cover it. Nobody wanted to cover it. So it was never anything that made me feel less than or insecure or anything like that. I felt very normal, and it gave me a beautiful posture, if anything. I also walked in the Victoria's Secret show for 8 years, and I swear I carried some of the heaviest wings, and I think that that fusion helped me carry those wings because they were really hard to carry and very, very heavy. So I walked in the Victoria's Secret show for 8 years. I was an angel for a few years. And then my proudest achievement is being a mom. And so these are my 2 boys. So pregnancy was another big unknown for me, and honestly very scary, because I had heard that it was, possible that I wouldn't be able to have an epidural. So I met with the anesthesiologist. My first son, Carter, this was 2020, COVID. I met with my original anesthesiologist and I showed him my x-rays, and he said, that's tricky. It could be tricky. We're not sure. There was never like a clear yes or no. So I decided that I needed to prepare mentally. So I did some virtual hypnobirthing classes just to prepare mentally for the potential scenario of not having any pain medicine or an epidural. Because of COVID, long story short, I had to change hospitals. I had to change anesthesiologists. I met the anesthesiologist the day of being in labor, and he was like, absolutely not. You're having this child naturally today. So thank God I had prepared with hypnobirthing, but it was definitely scary. And my biggest fear was not being able to handle the pain or having to go in for a C-section and just having to be completely under and not get to experience seeing my child being born. And thank God that didn't happen. I was able to manage the pain with a mixture of the hypnobirthing techniques that I had learned, a little bit of IV medicine, which saved me towards the end when it was getting really intense. But I had, at the end of the day, a healthy baby boy, and I felt, so proud of my body, what it could do. And then my second son, Rowan, on the right, I delivered him here in New York, and the anesthesiologist was open to trying. They were able to insert the epidural, no problem. I understood there was risks, but I said, let's just go for it, because I was actually more nervous for my second child, for my second labor and delivery. And so they inserted it fine, but I only felt the numbing from my hips down. So it didn't work 100%. I still felt all the contractions, but it did help me during the pushing and the delivery portion. So that's where I'm at right now. After having 2 kids, I do feel more stiffness, more pain in my lower back. So I'm trying to stay very active, very healthy. I've gotten back into yoga. I'm just really trying to prioritize my physical health so that I can stay as healthy and strong and feel good for as long as possible for my kids. So that's definitely my biggest concern right now. And I'm so grateful to be here today and to learn as well. So thank you so much.
Well, Lindsay, thank you so much. That was a really inspiring story, and you have accomplished so much, and it's incredible what you have been able to do, and so many different facets of your career. Next, Dr. Shufflebarger will introduce Michelle Marks, who is the stalwart of the Harm Study Group and the Setting Scoliosis Foundation. Dr. Shufflebarger, I'll yield to you.
I'm Michelle. I've known Michelle 25 years, and she's a remarkable woman, both in her early life as a physical therapist and in the organization and management of the Harm Study Group and the Setting Scoliosis Straight Foundation. It wouldn't be what it is today without Michelle. And she's going to talk about an exciting long-term follow-up study in AIS that's part of the Harm Study Group.
Thank you. Thank you, Dr. Shufflebarger, and thank you to all the speakers today. This has just been an amazing session, but we do have some exciting news that I'm really proud to share. The Harm Study Group is launching a long-term follow-up study. The next slide, please. This month, we just launched it, and it is looking at surgical patients, and we will be comparing surgical patients to patients that did not receive any surgery, as well as a control group of individuals that did not have scoliosis. This is going to be an international effort. Next slide, please. With a minimum of 20 years of follow-up. So we have 12 research sites. There's going to be 105 operative, non-operative, and no scoliosis individuals. It's going to take about 4 years to get this study done, but we're moving forward, charging forward, and thank you to Medtronic Spine for funding this first year of the study. Next slide, please. So we wouldn't be able to do it if this study group hadn't have been born in 1995 and we started collecting data on patients who had received scoliosis, and we have been following them in their journey postoperatively now for a minimum of 20 years. We were the leader in scoliosis treatment advancements, and Dr. Shufflebarger was actually one of the founding members of the Harm Study Group. Next slide, please. So these are all the sites that will be participating and in the surgical groups and the non-surgical groups, as well as coordinating for the controls. Next slide. But we need your help. This is a study that's going to take $500,000 to get done. We only have the first year funding right now. It needs an international fundraising effort. So please, if you are able to contribute, we would be so grateful to have this support. Thank you so much. Next slide. So just to close the webinar today, we really want to give a special thanks to all of our sponsors that sponsored the research of the Harm Study Group and the educational efforts of Setting Scoliosis Straight. Next slide. Please visit our YouTube channel. If not only do we have recordings of these webinars, but we have incredible infographic videos all about scoliosis and all of your important fun facts and questions, as well as patient stories and interviews. Next slide. We have one more webinar this year to close out 2023. That will be a webinar on vertebral body tethering, as Dr. Enercan had referenced the new technology that we are critically studying, and we are looking at who the best patients are for that procedure. So please join us for that webinar, and thank you for your support. Next slide. Please do answer our survey following this webinar so we can learn from you on how we can make these better. Always want to do better, and we really value your input. Thank you. Next slide. So thank you again so much to all of our speakers. Eve, Lindsay, you are both such beautiful people inside and out, and we're so honored to have you involved with our organization. And to Dr. Pizones, Dr. Enercan, Dr. Ohashi, Dr. Jain, and Dr. Shufflebarger, thank you so much. We are so proud to be collaborating with you, and we value your efforts to help us educate patients and their families. Thank you, and thank you for joining. Take care.